Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me for this talk. Thank you to Dr. Tafazzul, Dr. Aflaq. मुझे पता है कि ये आफ्टरनून है, आप ज़रा थोड़ा बोर होना शुरू हो गए होंगे. मेरी टॉक ब्रीफ है, इसलिए आप को ज़्यादा तकलीफ नहीं होगी. So the reason I chose this topic, in fact, I told Bilal that I want to do it, who was actually scheduled to do a talk on this, was because this is a very interesting case that I'm going to start with. And the reason I'm presenting it is that it's a little bit emotional to begin with. I'm going to present actually a case which is, I'm just recalling from my memory because I do not have his chart or any information available now. So this was a patient who presented to me, I would say about approximately 10 to 12 years ago. And during a very busy schedule, he was, I received a call from infectious disease, head of the department that, this is a very important patient, very important member of the community that you would like to see. So he was an add-on patient. He came to me, and his main complaints, so he was consider this that he was a marathon runner. He was a physically very gifted man in his early 50s. And what he presented was something that looked like relapsing polychondritis. Everybody's a rheumatologist in this room, so everybody knows what the common features are. So he presented with intermittent pain and inflammation in the ears and nose. But what was different was that he had febrile episodes, and he also had some weight loss. His appetite was not as good. And what was really different was that he had low platelet counts, and he also had shortness of breath, cough, and pulmonary infiltrates on the CAT scan that he brought with him. So at that time, I told him that the possible diagnosis is, one of the possible diagnoses is relapsing polychondritis, and then I would like to work him up for that. And obviously, since the things do not look very typical, so I would like to work him up for some other things too. So based on his clinical symptoms, I said that, top of the list is relapsing polychondritis, then there is lupus, vasculitis, and stuff like that. And since relapsing polychondritis is one of the vasculitides, I told him that this is falls in that category. So what he requested to me was that, tell me the name of the best vasculitis person in the nation, and I'll rather go to him because I don't want to take a chance if it's such a rare disease. So at that time, I had a close working relationship with Johns Hopkins Vasculitis Clinic. Dr. Philip CO is very famous now in the field of vasculitis, was one of the people I knew. So I told him to get there, and he was, because using all his connections, he actually went there. The patient fell off my radar for a while. I felt that, okay, a patient came and then, that's it. A few months down the road, or I think about, I would say closer to a year, the patient, I was called, so we were the thing about our practice was that we were the only ones who used to come to the hospital where I used to serve. And rest of the rheumatologists would not come to the hospital because everybody would make more money in their private practice. That's how in US it works. So if you come to the hospital, you're going to basically lose money. So that was the downside was that it was a very busy inpatient practice where a lot of rheumatologists turnover was there. The good side was that we would see all the difficult patients, even for the local rheumatologists. So by default, he landed up there, and I was on call, and I was called to see him again. And he got admitted for fever, chills again, thrombocytopenia, and pulmonary infiltrates, and was on steroids. So again, the infectious disease came, and they ruled out their own stuff. So I asked him what happened in between. So he said he went to the Johns Hopkins, and they tried different steroids, they tried immunosuppressants, but he keeps getting these attacks. So this was a little odd. A little bit more time went by, and he started getting admitted again, and this time around he was sent to NIH, which is the mecca for all these autoimmune inflammatory fever syndromes. So again, they could not do anything too. And then what happened was that finally he has been cycled through different DMARDs and some biologics. And finally, one of these admissions, I also got bored that I had nothing else to offer, and he keeps coming back. And in one of his final admissions, I told his wife when he was admitted, I said, we have done everything. You have been to Johns Hopkins, you've been NIH, what else do you want me to do? And then what happened was that I still remember that, that helplessness that I had when I went to his room. This was a guy who was a marathon runner, now shrunken, shriveled, small guy, lying there and asking me for help. And I still remember his final words that he said that, "Doc, could you save me? Is there any way that you could save me?" And at that time, like all the physicians in the room, when you don't know what's going on and the patient is very critical, you feel very, very emotional that, you are here to help him out. You're here to kind of save his life, but you could not do anything. So, and an interesting fact I'm going to also explain is in 2021, the ACR now, it's COVID time, the American College of Rheumatology is now remote. So the best time I'm telling you that I'm enjoying in education is now, because every lecture is recorded. In the ACR meetings, you don't have to rush around. You don't have to, at one time, 10 different parallel lectures are going on, and we used to miss them other than the one lecture we were attending. So this time around, I actually listened to every talk for the first time. And lo and behold, what happened was that there was a lecture on this vexus and a newly diagnosed disease. I don't know how many. Has anybody heard about this disease in the room? Yeah. So, so I actually got excited in that sense that I thought that this was what that patient had. So I called up my ID specialist friend, and he completely agreed with my perspective. By that time, he has heard about this disease too. So this is what vexus is. And that's why my topic of discussion was not relapsing polychondritis, but its mimics. So vexus, this is what stands for vacuoles, E1 enzyme, X-linked, autoinflammation, and somatic. So primarily, it's a sporadic genetic mutation. Sporadic means that it's not genetically inherited, but it's a sporadic by chance mutation, which basically affects the E1 enzyme, affects the UBA1 gene, which in return actually affects the E1 enzyme. So E1 enzyme is present in all the cells, which is important for what we call ubiquitation. Ubiquitation, remember that thing, ubiquitation. So ubiquitation basically means that when the cellular process routine is going on, this enzyme is required to remove the degradation products of the cell. And when this enzyme is not working, those degradative process does not happen, and all those protein which is not required in the cell is still there, which actually in result causes the antigenic stimulus, and as a result of which there is an unrelenting, widespread autoimmune inflammatory process that sets in. So the first article which was presented ever for this disease was in 2021 in New England Journal. So what the New England Journal people, that particular article mentioned was that we all know that there are a lot of illnesses where we don't know what that is. Like there is a febrile illness, platelets are swinging, joint disease, arthralgias, but no diagnosis made. So at that time, a group of physicians were basically, they grouped a lot of patients like that, and they started doing genetic testing on them. And once they were doing genetic testing on them, what they found out was this one commonality, this particular genetic mutation, UBA1 genetic mutation with similar kind of clinical symptoms. So that's when they published this article, and the first patient, there were about 25 patients then. One pearl I'm going to give. I try to give pearls in every of my talks so that there's some take-home message. So remember, if there is a relapsing polychondritis patient, remember this if you don't remember anything else. If there is a relapsing polychondritis patient where there is a macrocytic anemia, that means MCV is greater than 100, or platelets is less than 200, strongly think about vexus. It has got 100% sensitivity almost and 96% specificity. We are talking in relationship to relapsing polychondritis-like picture. This scheme of, this basically picture will give you a lot of symptoms as a part of vexus. The most important symptoms, as we already know, like there is going to be, a chondritis-like picture, ear and nose inflammation. But what is important is mostly they get, almost 100% they get a skin rash. And that skin rash is a vasculitic kind of a skin rash. If you do the biopsy, it will look like a neutrophilic dermatosis. And that's why a lot of these patients get confused with Sweet syndrome or anything which can cause leukocytoclastic vasculitis. So that's one of the differentials. The other thing which is very common in these is the bone marrow disorder. So myelodysplasia kind of a picture, which mainly is affecting the erythroid or myeloid cell line, is where you want to worry about. This is a very specific symptom as well. Other ones are relatively, also the DVT is also very common in this. So DVT, more common is the venous, which means about 40 to 50% patients will have blood clot in the legs or elsewhere, and about 15 to 20% will also have arterial clots, which is a very important thing as we know. And then there is pleural effusion, the lung involvement, the pneumonitis, and those kind of things, which also are pretty odd. This is a picture of the bone marrow from a VEXAS patient. These vacuoles, as you can see, is one of those VEXAS vacuoles. So V stands for these vacuoles in the bone marrow, which basically affect the erythroid and myeloid cell line. This is another picture of a patient who had VEXAS, or patients who had VEXAS. So you can see in picture A, there is a lung involvement with pneumonitis. B is vasculitis of the medium-sized bronchial arteries. C is the neutrophilic alveolitis, and D is vacuoles in the bone marrow. The skin biopsy which showed neutrophilic dermatosis and tender plaques or nodules, and then there's a chondritis picture. Cutaneous manifestation could be of any kind. Palpable purpura, leukocytoclastic vasculitis-like picture, nodules which are painful but not itchy, and these can be pretty widespread as well. Treatment. So treatment part is very important because treatment is evolving. So far it's kind of typically a fatal disease. Fatal disease means that patients will keep on getting these attacks, and they're steroid responsive for a little while, but then they stop responding. The drugs which I'll give you a nutshell. Different drugs have been tried, but the one which have shown some promise is cyclosporin for especially the inflammatory attacks, some help of tocilizumab, but I think the most effective, you should note it down, is ruxolitinib. So which is a JAK inhibitor, we call it Jakafi also. We have been using it for polycythemia vera, we have been using it for myelofibrosis. But this particular drug so far has given about 50% relief of symptoms in 50% of patients, which is a lot. So a lot of patients who are steroid dependent will not be more steroid dependent after using this drug. And so far, it can give you a remission for a year or more, which is kind of not very common. The only thing which can cure these patients is bone marrow transplant. So bone marrow transplant is a very tough situation in these patients because they're old age, typically they're above the age of 50, 60, 70, they have a lot of comorbid features. So they are not the best ideal candidate for bone marrow. I think so far about 6 patients bone marrow has been tried. 3 patients have been cured. I think 2 or 3 died after that because of the complication of bone marrow transplant. But this is one of the options for cure of the disease. So this is a part of the VEXAS. If you have any question about VEXAS, you can ask me. As I said, the field is evolving. Oh, one very important part about VEXAS is, as people think it's a very rare thing, it's, by the way, not that rare. According to the updated literature, not up to date, about one in 5,000 males can have it, and 1 in 10,000 females can have it. So it's not that uncommon too. As more and more genetic testing is becoming available, actually Mayo Labs regularly does this lab now commercially available, that if you feel like that, obviously it's not available here, but in US and those countries, actually this genetic testing is readily available and it's very sensitive and specific. So relapsing polychondritis, which is the other topic that it mimics obviously, is another rare disease. How many patients in this room has seen relapsing polychondritis patients? So 2, 3, right? In the lifetime of any rheumatologist, I think you're not going to see more than 3 to 5 patients at the most. Because one in a few millions, 1 in million or 1 in 2 million people are going to have relapsing polychondritis, which is very rare. Which means that after seeing thousands of patients, you're going to have 1 relapsing. Another thing actually why it is rare is because it is relapsing. Relapsing means that the patient is going to have some symptoms. For example, a lot of patients who have a minor kind of a subset of this disease are going to have a symptom, but then the symptom will disappear. And then during that episode, patient may be self-medicating with ibuprofen or any kind of an NSAID, and the symptom will go away. And that's why actually I think it's relatively rare. These days, the classification, like, remember when in myositis, I used to give that lecture to you guys. Myositis was polymyositis, dermatomyositis, which is not the classification anymore. We all know that the classification of myositis is antibody-based. Similarly, the field of relapsing polychondritis is evolving too. It's not, they're trying to divide it into different subsets. It's a relatively lengthy, boring process, so I'm not going to go into that detail, but coming in a few years, you'll see a very different classification of relapsing polychondritis. Another take-home pearl, if the kidneys are involved, it's not relapsing polychondritis. So take another message. The first case of RP was described in 1923 by Jacques Wartenhorst, probably a German scientist. Then the term relapsing polychondritis was first used by Pearson in 1960 in their review of the first 12 cases, published cases. This is typical McAdams criteria and Damiani and Levine criteria. To tell you the truth, it will become obsolete soon, so I'm not going to go into that detail. As I said, the new classification will be based on the subset of patients and how they are. Everybody knows about this, right? The ear involvement, especially for the students, I'm sure the attendings already know that. If you have repeated attacks of ear chondritis, first of all, what is the tip off? How is this? What is the clue in this picture that tells you that this is relapsing polychondritis ears? Anybody can tell that? So it's involving the cartilage part of the ear, right? Cartilage. It's sparing the lobule. So basically, this is a relapsing polychondritis picture. What is this now? Infection. And you know why it's an infection of the ear? Because you can see like there is an entry point. So typically such kind of ears happen when the girls go for the piercing and the piercing is not done in a proper fashion, the ear piercing, and you can get an infection. Or you are a diabetic and you get an ear infection. Or if you have an ear surgery and you get an infection or insect bites. But the previous picture was not in. But why I'm putting this on is because a lot of patients with relapsing polychondritis gets confused with infection. Rugby players. You know what is if the patients with relapsing polychondritis keep on getting attacks untreated, what happens? What is the final version of the ear? What is the catchy name for that? So cauliflower ears. Cauliflower gobi ki tarah ki jo hoti hai us tarah ki picture. These are again cauliflower ears, but this is a rugby player. In rugby players, especially the front runners in the front people, they get their ear damaged quite frequently. And then they develop the clots in the ears. With repeated damage, they develop cauliflower ears. Very different thing. This is not to be missed too. So lymphoma of the relapsing can really mimic as well. This, I am presenting a case report. In this case report, what was the clue was that although this is bilateral auricular chondritis, but the other ear was almost completely involved. So that was the clue. So whenever that happens, you have to take a biopsy, and this was a low-grade lymphoma. The patient was treated with splenectomy and chemotherapy, and he went into remission. Not to be missed. Antiphospholipid antibody syndrome ears. Everybody knows about CAPS, what CAPS is. So in CAPS, you can have this kind of a presentation. Again, the whole ear is involved. It's very painful, and necrosis can happen. So one of the differentials that you're going to run will be antiphospholipid antibody syndrome. This is leprosy. So what is again the tip-off is the whole ear is involved, and you have skin nodules there. And this patient, when he had the biopsy, the acid-fast bacilli were seen. Now, anybody in the room can tell me about nasal chondritis, how does it present? What would be one symptom? Pain? Yes or no? Right? Yes? It will be, it's an inflammation, right? Would there be a lot of erythema or swelling? Very good. I think only Yasser and Bilal are awake. I think everyone else is sleeping. So it's not that boring, guys. Wake up. All right. So what happens is that with repeated attacks so what you're going to tell what you're going to ask the patients about it is that you don't ask them, you should ask this directed question, where is the pain? If they say that it's at the tip of the nose, it's not, chondritis. If they say the pain is in the base of the nose where the nasal bridge is, that's where the pain, that's where the clue is. So with the repeated attacks, what happens is that they develop this particular ear which we call nose, which we call saddle nose deformities. This is where the money is. This is where the things become more serious. If it's only the ear and nose involvement, it's not that serious. But when we have the airway involvement, has anybody seen any patient of the airways? I've seen actually patient, which one of the patients actually a co-managed with Johns Hopkins. Again, airway disease is where you should become very serious. So if somebody's so the airway is also divided between upper airway and lower airway. You know, the lower airway patient can present it's a very lethal disease, and it can be a very emergent situation. They can present with acute shortness of breath and asthma-like picture, because remember that it affects the cartilage. So neck has cartilage, thyroid cartilage. It can present in the form of neck pain, trouble swallowing. It can affect the vocal cords, so dysphonia or hoarseness. When it affects the trachea, you will have obviously inspiratory and expiratory problem and stridor, etc. But when it affects the lungs, it can be very asthma-like picture, because the reason is whatever cartilage is in the bronchioles and bronchi, they basically will melt also, and they will start collapsing, and there'll be a lot of inflammation and edema, which can lead to bronchial obstruction and asthma-like picture. This picture gives you a tracheal involvement. As I said, lower part can have cough, thoracic pain, wheezing, respiratory failure, and it's emergency. When the airways is involved, remember what you have to do is you have to do a CAT scan of the face, CT scan of the chest, and the CT scan of the chest should be done as a dynamic CT scan, which means in inspiration and expiration, both, because you're going to see this collapse of the trachea in inspiration and expiration. This is very important. This should not be missed. Tracheobronchiomalacia is a potentially lethal disease, life-threatening. This is a picture of a tracheal involvement, where the first one shows active disease, and the second one is after improvement in the trachea after the treatment. Ocular involvement, like any other inflammatory vasculitis, it can cause scleritis and episcleritis and uveitis, so remember that too. Cardiac involvement, another very serious thing. So like lung involvement, cardiac involvement is very important. And what it affects is the thoracic. So this is, as compared to the other things that I mentioned, this is a late complication. So somebody who has repeated attack of relapsing polychondritis involving the ear and nose, don't dismiss it. 5 years down the road, they can have a cardiac involvement. And the cardiac involvement is mostly around the aorta. It could be the thoracic aorta, abdominal aorta, and it can also involve the aortic root. So aortic valve can be involved too. If you do not take care of it, finally aortic dissection and rupture can happen too. And like any other vasculitis it can also affect the endocardium, myocardium, and epicardium, pericardium. And the resulting, you all know that can lead to pericardial effusion. In fact, my patient had pericardial effusion, the one I sent to Johns Hopkins along with the tracheal involvement. Costochondritis, like cartilage anywhere else, you have cartilage in the rib cage area. It will present in the form of chest pain. Everybody in this room knows about costochondritis, its presentation and its clinical findings, so I'm not going to go into that detail. Articular involvement. This is the only easy part. The joints are never that bad. Means you're going to have a polyarticular, it can be symmetrical, it can be asymmetrical, it could be large joint, it could be small joint, it could be even spondyloarthropathy like picture, but it never is destructive, it's never is erosive. So this also is a very important slide. You might want to take a picture of this. What not to order. What not to order is the anti-collagen 2 antibodies have a very low sensitivity and specificity, only 20 to 30%. So therefore they're not useful in making a diagnosis. And I don't think they're commercially available for that reason. Biopsy of the cartilage. Biopsy of the cartilage should not be done until and unless you think it's a lymphoma and you have some reason. If it's a very classic picture, don't take a biopsy because it is an invasive thing to do. Relatively non-specific results if it's not a lymphoma or infection. Similarly, inflammatory markers can be deceptively normal. It's a very complicated disease, a lot of relapsing. So 50% of the patients have seen 3 physicians before they come to make a diagnosis. Treatment. So the milder cases, we all know, they heal with just NSAIDs intermittently, and that's why many patients show up very late, because they're taking NSAIDs on their own. If it becomes relatively more chronic, colchicine can be tried. If colchicine fails to protect these joints or protect these attacks for 6 months, you want to stop colchicine. Dapsone used to be one of the criteria. Response to steroid and Dapsone used to be one of the criteria. But Dapsone is a very complicated medication, a lot of side effects, and it can lead to some irreversible damage in case of G6PD. So make sure if you have to start it, you check the G6PD levels. Injection of steroids wherever the joints are, and the prednisone in short term if everything else is not responding. Then come the synthetic DMARDs with methotrexate, leflunomide, MMF, and biologic DMARDs in the more difficult cases. Anti-TNF and IL-6 blockers have very good results, and limited role of surgery. Treatment of the airways is very important. Remember this thing. If somebody is having an acute tracheal obstruction or they are having severe subglottic stenosis, tracheostomy will resolve the issue. As we all know that tracheostomy is life-saving, and the upper airways you can manage just by tracheostomy. Lower airways is very dangerous. So when you're really thinking that it's more of a low tracheal involvement or lung involvement, you have to, and it's a very emergent situation, you may want to pulse them with steroids. So in very life-threatening cases, you pulse them with IV steroids, gram a day for 3 days, followed by cytoxin, and then further azathioprine, etc. Role of biologics, as I said that in this disease, the main role is with infliximab and adalimumab. Good response in most of the patients. Tocilizumab in most of the patients as well. Abatacept has a limited role so far. And JAK inhibitors are being studied right now. Final slide is, I want to mention about this MAGIC syndrome. How many people have heard about MAGIC syndrome? Right? So MAGIC syndrome basically means it's a Behçet's disease along with relapsing polychondritis. Everybody probably knows about Behçet's disease. It's basically an oral and genital ulcer disease. And when combined with relapsing polychondritis, it's a potentially quite a lethal combination, because this is a subset of patients who can have anything. Raynaud's phenomena, skin disease, lung involvement, even vexus, thromboembolic disease. So remember that you don't take it that non-seriously. Very few cases though. So overall, I think reported cases about 50 or so. So in summary, this is the final slide. It's a very heterogeneous disease. It can present in any shape or form. Diagnosis is mainly clinical. There's not a blood test to diagnose, not a biopsy that should be done. The poor prognostic signs are male gender, hematological involvement, respiratory and cardiac involvement. Vexus is a very serious subset, very serious subgroup of the relapsing polychondritis with very high mortality and needs genetic testing. Early diagnosis and treatment requires collaboration between rheumatology, ID, ENT, and pulmonary, and new modalities of treatment are evolving. So here I stop, and if you have any question, you can ask now.